Welcome, one and all. We now move to what I think is going to be a very interesting and important session entitled Improving Outcomes for Medicare Advantage Patients with Diabetes. Now, this is important because I think we're seeing frequently now of late various studies and reports reflecting the superiority of Medicare Advantage over traditional Medicare, still somewhat controversial, but it's Medicare Advantage writ large and writ large as a monolith. I have often been interested in, the Medicare Advantage that is full risk, two-sided risk, and we've had another presentation on that before during the conference, and we're going to have yet another excellent one now. It is indeed my pleasure to introduce our guest, which is Ben Kornitzer. He is the CMO of Agilon Health. Ben received his AB from Brown University, his medical degree from Mount Sinai School of Medicine. He completed his residency at Harvard Medical School, Massachusetts General Hospital, and he's been the CMO now at Agilon Health for a number of years. Ben, I'll let you describe Agilon, a rather unique and excellent organization, doing extremely well, I might add. So when we get to that. So with that, one more little intro, Ben, if I may, or one little level setting item. Your deck does this excellent job of describing what Agilon refers to its total care model, or the Agilon model, I think. So I treat that as synonymous with what I would call full risk, upside and downside two risk model. It's got many other names. It's capitated. So is that understanding correct? Is that a good level setting?
Yeah, no, I think that is correct. We really use the word total care with the notion that our partners are really responsible for the totality of the quality of care that's delivered, as well as the efficiency of that care. And it's that level of accountability and ownership that we find to be really impactful, and look forward to discussing that a little bit more shortly.
Excellent, excellent. Let's go through your deck. And then after the deck, we'll have a conversation. So let her go.
Well, very much looking forward to it. So, just to level set, a little bit, we released a white paper on diabetes in January. But I do think, as you mentioned earlier, there's really a unique opportunity in the value-based care space to elevate our knowledge and generate new insights that extend to many aspects of care, and whether that's, PCP access, quality, chronic care, physician engagement. So this is really just part of, I think, a larger dialogue that we're having in terms of value-based care, and very much looking forward to partnering with you and with others around the country to really elevate our knowledge and improve care for seniors. As you indicated earlier, we're going to be spending the conversation today talking about this research around diabetes. And diabetes really is a perfect model to understand whether a value-based care program, particularly one around primary care physicians, is delivering and performing on its potential. So why diabetes? Well, first of all, we should understand that chronic conditions, of which diabetes is the most prevalent, account for 90% of healthcare spend. Over one quarter, so anywhere from like one quarter to a third of patients over the age of 65 have diabetes. We actually know that the incidence of diabetes, so the new cases, are increasing significantly year over year as the population ages, as the obesity epidemic, goes on without abating. Diabetes is also very relevant because it's so harmful. So the way that diabetes works is elevated blood sugars causes micro and macrovascular damage that can affect virtually any single organ system. And as a result, it's extremely costly. So it's the number one cause of adult blindness, kidney failure leading to dialysis, limb amputation, leading cause of heart attacks, strokes, premature death. If you take all of those together, 1 out of every $4 spent in healthcare are spent on diabetes. And then there's the other component in terms of the distress it causes patients. So managing diabetes causes tremendous emotional distress to patients. The levels of depression are much higher in this population. And then lastly, and this is why it's so critical, all of these complications of diabetes are avoidable by better controlling blood sugars. That is something that primary care physicians are uniquely positioned to do. So earlier on, we talked about, what is the value of a total care model and how does it work? So as a PCP, I can tell you there is no more powerful intervention in healthcare than the trusting relationship between a PCP and his and her or her patient. We know from research that primary care access is one of the few interventions that actually can move the needle on the cost and quality of care. Communities that have access to primary care, patients live longer. Well, as a PCP, I can have tremendous impact on my patients within the four walls of that office, of my PCP's office. The majority of a patient's healthcare journey occurs outside of the four walls of the PCP's office. And in a traditional fee-for-service model, primary care physicians have had very limited ability to either see what's happening outside their four walls or to impact what happens or to be accountable for that care. And so patients fall between the cracks. They're lost to follow-up. Patients may be homebound. If someone else writes a prescription for a patient of mine, or even if I myself write that prescription, do I really know whether that patient is taking that medication or filled that prescription? Important longitudinal data gets lost if patients switch health plans. I'm not really sure as a PCP if someone has seen a cardiologist or what happened during that encounter, if they go to the hospital or to the emergency room. And as a result, that's how patients fall in between the cracks and have poor outcomes. And so what you see at the top right here is how that manifests. That manifests in patients getting fewer diabetes eye exams. And so you see that here. And that manifests itself in patients having poor control of their blood sugars. What's so powerful, and I think what our research really showed, is that in a total care model, if we are able to go and really remove the four walls of that PCP's office, if we're able to bring all of those resources closer to the PCP so that they now know which patients are lost to follow-up or homebound or which medications those patients had or who went to the emergency room, they really have an ability to change the way that patients experience that care. And then also you can invest in resources ahead of outcome. So for example, for our diabetes patients, you can invest in pharmacists, care managers to make sure patients are taking the right medications. You can invest in retinal cameras to make sure that patients are getting their eyes examined without having to make a separate trip to the ophthalmologist's office. And then what you see by doing that work, those same exact PCPs who were underperforming in 2020, virtually all of them are achieving at 5 stars or above on a critical measure of diabetes quality care. And so really, when you look at scale, it's the notion of how do we reduce that variability that harms patients and get better outcomes. And that's what we're going to be talking about today. So we look at physicians in that new model of care and see how they're performing. As Dawn, you mentioned, there's been a significant amount of literature, particularly recently, showing better healthcare outcomes for patients in MA in terms of quality and efficiency, particularly in two-sided models. So when we took a look at our cohorts of patients in 2020 and 2021, for eye exams, we saw that our patients in this model were 3.2 times as likely to see year-over-year improvement than overall MA. And you can see they're dramatically higher than even the highest performers. So that's programs like CPC Plus within the fee-for-service framework. Next, if you go and take a look at hemoglobin A1C control, so again, these are blood sugar controls, what you see there is compared to the fee-for-service benchmark, and this isn't just any fee-for-service, this is the top performing practices within fee-for-service, CPC Plus, that get approximately 13% additional revenues to cover resources and have been involved in these programs for 5+ years. You see the outcomes that we're seeing year over year, 3.8% improvement. And really the value of a healthcare organization should be measured on something very, very simple. Are we improving care? Are patients that we see today getting better care today than they would have received yesterday? And are the patients that we're seeing today going to get better care in the future because of the investments that we're making? The next point that I would like to highlight is, not only are we seeing improvement in terms of the quality of care with those traditional STARS measures, but those patients with better blood sugar control are also getting significantly better data in terms of how they're utilizing care. So of patients with well-controlled blood sugars, 50% fewer of them are getting admitted to the hospital. In fact, 85% fewer hospital admissions for diabetes-related conditions. And I would point out that, when you talk about seniors, a hospital admission is a non-trivial event. 40% of seniors who are admitted to the hospital wind up being discharged having lost a basic activity of daily living, the ability to bathe themselves, rest themselves, feed themselves. And so really a hospital admission for a senior can start a downward spiral that changes the entire trajectory of their life. We also see that by better controlling patients' blood sugars, they have significantly lower cost of care. And that cost of care also results in lower out-of-pocket spend for those same patients. So approximately 20% fewer out-of-pocket dollars. Now, we know that seniors, particularly seniors on a fixed income, healthcare spend is very significant. It's about 1 out of every $5 that they have go to healthcare. And so our ability to get more efficient care could be the difference between paying for their utilities during the cold winter months, having nutritious food, or being able to afford their medications. And these were the cost of care during the initial year of measurement. If you'll remember from that earlier slide, we talked about the pathogenesis of diabetes, the vascular damage that leads to the most serious complications, again, blindness, heart attack, failure, renal failure, going to dialysis, strokes, those tend to occur over 3 to 5 years or greater. And so the fact that we are really investing in better quality outcomes today for these patients is going to mean that they're going to continue to do better year over year. Fewer patients will lose their vision. Fewer patients will wind up on dialysis. Fewer patients will lose a limb. Now, something that's really important to me as a physician, to my colleagues, I think, to stakeholders across the country from CMS to AMA is health equity. And so one of the things that we're most proud of is by, really doubling down on a total care model, we see that patients in medically underserved areas are getting essentially the same exact level of diabetes control that they do in medically well-served areas. And that's absolutely critical for our, mission as an organization, I think where we need to go as a country in terms of developing better healthcare. Now, when you take a look at those underserved communities, right, they're underserved based on location, based on things like access to care, based on outcomes. We actually wrap more services around those patients. So you see those underserved patients are getting more touch points with their PCP. So we're improving access. In fact, they're getting significantly more annual wellness visits. So 95%, I think the national average in fee-for-service is still in the 30 to 40% range. And then when it comes to areas of acute utilization, right, they're winding up in the hospital less frequently. They're winding up in the hospital for avoidable, so ambulatory sensitive conditions, significantly less. And in terms of emergency department utilization, which tends to be very high in these communities, we actually see fewer visits to the emergency room. So, more than anything, I think the ability to really measure what we're doing, take a look at these vulnerable senior populations with chronic diseases in underserved areas and raise the bar in their performance is really important to us as an organization. But I think it also gives implications for how we deliver care nationally and how we think about investing in primary care, how we think about chronic disease management, diabetes, CHF, COPD. So anyway, Don, very appreciative of the time to share some of our results and very excited to continue this dialogue.
Well, those are very, very impressive results indeed. So thank you very, very much. Well, at the risk of perhaps asking you to repeat something you've already said, tell me again, what's the magic of full risk? What's the incentive going on here? What's the psychology behind it? What is it? Why does it produce these kinds of excellent results when other payment models don't?
Don, that's a great point. If you think back to that sort of framing slide I had about, what a PCP does within the four walls of their office. So in a traditional fee-for-service setting, you really can only control the patient who's in front of you at the moment. There's no incentive, there's no sort of resource allocation for a broader team that might include pharmacists and social workers or investing in things like retinal eye cameras, or having team members whose job it is to identify patients who have fallen in between the cracks and may not have come in 6 months or 12 months or a year or two. And so it's a very different mindset. I think, when we've talked earlier, I've sort of said fee-for-service is a hobby. You see the patients that you see who show up on that day, and that's it. Value-based care, a total care model, is really about a process. It's a practice. When I talk to my friends who do meditation, they never say it's a single thing they do. They talk about their practice. What do you wake up in the morning and think about? When you're not going into the office, who's thinking about your patients? What team members are you using? How are you compensating people so that they really have accountability for outcome? It's a completely different mindset. And again, it's not about what happens in the moment. It's about how you're reorganizing the entire care delivery around the PCP.
Ben, let me ask you a clarifying question about where upside and downside risk is. So within agilon and its partners, there's no question that it's at the top level, but would you speak to the downstream risk that as it may or may not apply to the primary care physicians that are within those organizations?
Yeah, absolutely. So, primary care physicians in general are responsible, through their own personally performed services of anywhere from 5 to 10% of the overall healthcare spend. But we know that they have the ability to impact virtually all of that spend, 80% plus. And so if you think about a patient with heart failure, your ability to better manage patients with heart failure can keep them out of the hospital, significantly better outcomes for those seniors. Really, if you think about the type of models we go into, so we have partners that have been in their community for, over a century. We have, one doctor that I recently spoke to who's a third generation country doc living on his grandfather's, farmhouse. And so these are deep relationships they have. And so really what drives them more than anything is the ability to improve care for the patients that they take care of. The real disruptor of our partnership through these markets is our ability to work with them and basically have 100% upside downside risk. And for that surplus that's generated by higher quality, more efficient care, similar to what you saw with those patients with diabetes, these physicians can now reinvest that in things like pharmacists and care managers and social workers. So their patients with diabetes or heart failure or COPD aren't winding up in the emergency room, aren't winding up in the hospital, aren't having all sorts of other avoidable utilization that's harming them and taking a lot of out-of-pocket spend from those patients who could use that money for a lot of things that are probably going to be much better for their overall well-being. And so it's the fact that there's tremendous resource available to them now.
Got it.
You think a third of healthcare spend is waste. And so if you can then rededicate that healthcare dollar to things that actually benefit the healthcare community and their patients, that's tremendously appealing to our partners who, as I said, many of them have been in their communities, for generations.
Very, very good. Thank you for that. Okay, sticking to the economics of this just for another second. So you, I assume, through agilon and your partners, are obligated to pay for hospital claims. You have institutional risk. Tell me about that. Does that create an opportunity for more profit or loss? How does that influence the economics of your model?
Yeah, so if you think about it, primary care, depending on, the geography and the practice, could be anywhere from 5 or 10% of the total cost of care. But those PCPs really are responsible for the outcome of 100% of that care. So if you really think about it, things like our patients with heart failure being well managed, right? So a PCP visit, is a very efficient touch point to do things like titrate someone's medications and avoid a hospitalization that can be devastating for that patient, right? So could change your trajectory of that patient's life. They wind up in the hospital, they get a nosocomial infection, they have a fall, they break their hip. Bad things happen in hospitals, and through a PCP, even though it's such a small amount of the actual healthcare spend, it has such tremendous impact on better outcome. And so the fact that PCPs are incentivized to spend that extra time to be able to go and get resources that they otherwise might not. So the example I was giving with heart failure, the ability to go and contract with pharmacists to go and make sure that patients are on the right dose of their diuretics, that they know how to take those diuretics, that we're able to do things like track their daily weights, their daily blood pressures. All of those investments upstream of the outcome have the opportunity to dramatically change how patients experience care.
So you mentioned the word implications a minute ago and started, I think, to use the word policy. Let me start with business implications. So here is Agilon. You'll have to clarify my misdescription of Agilon and its partnership, perhaps, but it provides a host of services to its partners that it works with, mostly multi-specialty groups, I think. Have you, because of the superiority of this model, been able to spread it across the entire agilon community, or not? Or are you still operating in some fee-for-service models and other? Have you successfully spread it across the entire enterprise?
Yeah, so our thesis is, to be successful, you need to do a few things. Number one, you need to move to a full risk relationship immediately. Mm-hmm. So all of our new partners, we bring them fully up to speed in 12 months or less. The next thing is you need to do it at scale, mm-hmm. right? So if you really want to flip a market and have a value-based care, opportunity, you really need to do it with significant scale. And then the last part is you want to focus on those populations that are highest risk, and that tends to be the senior population. And so all of our partnerships, 100% move to that full risk total care model, within that initial implementation year. Again, I think that there's ample evidence that sort of, incrementalism, small upside, small downside will never allow you to get the resources you need to invest ahead of the outcome in all the things we talked about. And so again, with diabetes, pharmacists, social workers, care managers, potentially doing home visits, the ability to do remote patient monitoring, all of those things require significant investment. And if you do not enter into sort of a total care accountable relationship, it's really impossible to have the impact that you need to have.
Wow, that is a really important observation, I think, finding. So let's turn to policy implications. So here you are, Secretary of HHS or King of the Manor or something. What should Congress, what should CMS do with this kind of finding and experience you've had?
Yeah, listen, I think everything we do should always be centered around patients and their outcomes. That saying that I think has been misattributed to Einstein is the definition of insanity is doing the same thing over and over again and expecting different results. So it is clear that, traditional fee-for-service, and I think everyone's on board, hasn't given us the results that seniors deserve. Yeah. I think what is increasingly apparent is that putting resources around primary care physicians, reorienting the entire care delivery system around PCPs who are fully accountable for those outcomes and giving them the opportunity to reinvest so that they can get the resources they need, whether it's technology, whether it's additional team members and operators, whether it's additional clinical resources like pharmacists or NPs or care managers. Having that reorientation, creating the economics to do so, creating an environment where primary care physicians can really innovate, I think is essential. Primary care is really the backbone of U.S. healthcare. And for a long time, it has been sort of the stepchild of our economic delivery model. And so I think that this data is very compelling. It's not just about better primary care, it's about better outcomes for seniors, it's about better care for our entire country. And, I think about some of my early experience with diabetes patients, right? I remember as a medical student seeing patients in the emergency room who had a limb amputation or were going back and forth to dialysis because they had kidney failure from uncontrolled diabetes. And they weren't just suffering. Their siblings were there with them or their children were there with them. It is a tremendous burden on those patients. It's a tremendous burden on their family members. For those people who didn't have family members, these patients often became wards of the local government. And so the implications societally on getting this right are just so huge. And so I think that this really reaffirms the value of much deeper risk models investing very, very deeply around primary care and doing it in a very disruptive way. So again, not incrementalism where you give people 5 or 10 years, but really saying we are going to flip the model overnight because that's the only way to have the resource necessary to have a deeper impact.
We need to put a bow around what you just said, Ben. Thank you very, very much for that summation. They are giving me the hook based on the clock here. Any closing thoughts, anything that we've missed, anything you'd like to add?
Yeah, I think there's a larger national dialogue around chronic care management. So, how do we think not just about our diabetic patients? How do we think about our patients with heart failure, with COPD? Cancer is increasing, becoming a chronic disease in America. And so thinking about how do we create the economics and the infrastructure? How do we share data better? How do we make it easier for PCPs in their practice to know what happened in a specialist office, what happened if one of their patients was in the hospital, the emergency room? So really breaking down those barriers, I think, is going to be, increasingly critical. And then I think we just need to have comfort as a country moving much faster to value, right? What I tell people is run, don't walk.
Yeah, well, that was on those words. I think we'll go ahead and wrap it up. And thank you very, very much for this, Ben. I think you were fantastic, and have a great day. We'll see you soon.